The following podcast is part of a certified educational activity titled, "It's Precisely the Time for More Precision in Genomic Testing and Targeted Treatment of NSCLC." Access the entire activity and complete the post-test at peerview.com/NEN860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Rebecca Heist from Massachusetts General Hospital Cancer Center and Harvard Medical School in Boston, Massachusetts. Welcome to this educational activity on genomic testing and targeted treatment of lung cancer. Joining me in this discussion today is Dr. Jacob Sands from Dana-Farber Cancer Institute and Harvard Medical School. Welcome, Jacob.
Thanks. I'm looking forward to the discussion.
Great. So let's get started. Today we're going to talk about four main questions relevant to current practice in lung cancer. First, why test lung cancer patients for genomic alterations? Then, which genomic alterations need to be tested? Who needs to undergo molecular testing? And how to test for genomic alterations. So why test lung cancer patients for genomic alterations? We know now that precision lung cancer care isn't just a pie-in-the-sky dream. It's increasingly more important to do better, well, as we consider the complexity of lung cancer and expand and refine on the approach to precision treatment of our patients. We know that genomic alterations are common in non-small cell lung cancer. In the French cooperative thoracic intergroup study, half of non-small cell lung cancer patients tested positive for genomic alterations. In the Lung Cancer Mutation Consortium, 64% of non-small cell lung cancers tested positive. And now there are 7 genomic alterations occurring in non-small cell lung cancers with FDA-approved targeted therapies, and many more coming. We all were aware of the FDA-approved therapies in EGFR, ALK, ROS, BRAF, and NTRK, and just this last month, new approvals in MET exon 14 skipping and RET. Non-small cell lung cancer, we understand, is complex and heterogeneous. And while we used to think of it just in terms of histologies, subdividing it into adenocarcinoma, squamous, and other non-small cell subtypes, now we subdivide it even further into specific molecular genotypes. Jacob, do you want to comment on how we think about non-small cell lung cancer subtypes now?
Yeah, I'm happy to do so. We're in an exciting time in lung cancer, and we've really seen a lot of advances over the last decade, and this slide kind of highlights that. So non-small cell lung cancer, this is a complex and now heterogeneous disease, as has been demonstrated. So we see here that about 60% are adenocarcinoma, about 20% squamous cell, and until recently, that was really the understanding of non-small cell lung cancer. Now on the right side, we see there the heterogeneity of the disease, and this is really stratified out by genomics. So KRAS mutations, EGFR mutations, ALK, fusions, and so on down the list. And as more and more gets discovered and as more targeted therapies become available, this pie gets sliced into smaller and smaller pieces for really more focused therapy.
And I think the really interesting thing is we know that treatments aimed at these targets produce better treatment outcomes. We're always trying to match the patients to the right targeted therapy. We think if we do that, there's higher response rates and improved quality of life. And we may be able to avoid chemotherapy for a while, at least, for many of these patients. So there are many examples in EGFR, ALK, ROS, BRAF, now MET skipping and RET, as well as NTRK, where a targeted therapy produces a response rate that's extremely high, and we think really is the best upfront treatment for these patients. We also know that immunotherapy has a relatively lower efficacy in specific molecular subtypes in lung cancer. And we think about this a lot in our patients with EGFR, ALK, ROS, for example, where we worry that even with high PD-L1, these patients don't necessarily get the same benefit as others with immunotherapy. Indeed, there have been multiple studies that show that if you follow immunotherapy with a targeted therapy, there can be increased toxicity. This is just one example of a study taking patients with EGFR mutations, treating with pembrolizumab until progression, and then an EGFR TKI afterwards, And what they saw in this study was that there were toxicities here which are concerning, including pneumonitis, which can be grade 3 to 5. And this is something that we worry about anytime that we're following immunotherapy with a TKI. Jacob, how do you think about immunotherapy in your patients with a specific target?
I think one of the challenges now in having all of this is that it takes a little longer to do the workup to get the specific diagnosis. So people come in, they're anxious, they want to get started on treatment, and the challenge is to explain to them, hey, we really need to do this analysis of your cancer DNA before defining the treatment, and people want to get going. So what I often tell them is, hey, I want to do this workup so we can get you on the best treatment, not just get you on the first treatment. And I find that that line for many patients tends to click and they go, okay, yeah, I want the best treatment. Now, that being said, sometimes people are symptomatic and we really have to start them on the first treatment. And when that comes up, what I'll often do is give them just the chemotherapy portion. So maybe we have their PD-L1 expression. Their PD-L1 expression is 90%. That becomes very tempting to give them immunotherapy. But I tend to hold off. I give them just the chemotherapy if I have to start something, and then wait for the genomic testing to come back because of exactly what you're highlighting there. So if you start immunotherapy and then they come back and they have an EGFR sensitizing mutation, well, now adding, or even a switch over to that targeted therapy, you really risk complications because that immunotherapy is on board. It has a long half-life, and it becomes harder then to change over. So I'll do chemotherapy for the first cycle. At that point, you should have the results typically by the time second cycle comes around anyway. And at that point, if there is something, you can go on targeted therapy, or if there's not, you can still add in immunotherapy if that's the right clinical scenario.
So which genomic alterations need to be tested? As we carve out more and more slices out of the non-small cell lung cancer pie, all of us are familiar with the established targets such as EGFR, which showed us the importance of genomic testing and using matched targeted therapies. But now the next wave of novel targeted therapies directed to rare but important genomic alterations has arrived. So what do you need to know? Here is a graphic showing the molecular targets with FDA-approved therapies, and we're going to go through these one by one. EGFR we're all very familiar with. RET and MET exon 14 skipping have had new approvals recently, and ALK, ROS, BRAF, and NTRK are all targetable alterations as well, with approved therapies. In addition, we'll touch on briefly some emerging targets such as KRAS G12C and HER2. Jacob, can you talk to us about EGFR?
Yeah, I'm happy to. So EGFR is really the first one. This is 2009, the IPASS trial looking at first generation EGFR TKIs really kind of kicked things off in a lot of ways clinically. And since then, we've now seen multiple EGFR-directed therapies. But it's important to note that not all EGFR mutations are sensitive to all these therapies. So we talk about EGFR sensitizing mutations, and really the classics are exon 19 deletion, L858R mutations. But exon 20 is a different category, and we'll kind of talk about that. So it really is important, the specific EGFR mutation. So when we're having this discussion right now, we're going to be talking about the EGFR sensitizing mutations. So more recently, third generation EGFR TKI, Osimertinib, has really become the standard of care in the US. This was really from the FLORA trial, which looked at Osimertinib versus first generation EGFR TKIs, which are Gefitinib and Erlotinib. And really, Osimertinib was superior in every way. Better progression-free survival, better overall survival. Osimertinib has shown very good CNS penetration. And so, and on top of that, has also been better tolerated. So it's kind of everything you want from a drug. And so this has really become the standard of care. The resistance mutations to Osimertinib are a little bit different than the first generation EGFR TKIs. So Erlotinib and Gefitinib, the resistance mutation most commonly developing from that was T790M, and this was something that made the cancer resistant to those therapies. Now, this was kind of the first inroad for Osimertinib because T790M is sensitive to Osimertinib. And so for those who developed a T790M mutation, Osimertinib then was used to treat that resistance mutation. Now, Osimertinib now being the frontline standard of care. T790M is not really in the picture as much, but there are other mutations that show up. One of note is C797S. So C797S doesn't happen as often for resistance to Osimertinib, so we see it a little bit less than we saw T790M to Gefitinib and Erlotinib. But that is a resistance mutation to Osimertinib that is sensitive to Erlotinib and Gefitinib. So there are some cases now where patients are started on Osimertinib and then later on end up on one of those first generation EGFR TKIs if C797S shows up. I think the important thing to note really is that when you're doing this genomic testing and you find that there is a sensitizing EGFR mutation and you put somebody on Osimertinib, at the time of progression, it's still the same kind of a scenario as it was before. So we need to do genomic analysis and look for resistance mutations. Now, that can be done a handful of ways, and I think we're going to discuss the testing a bit more later. One thing to note with EGFR mutation lung cancer is when there is progression, if there is a suspicion of small cell lung cancer transformation, which we do see happen, then that really requires a biopsy. Genomics testing itself can be done from a blood-based test or from a biopsy. And in many cases, what I'll do with someone when they have progression, when they have progression, I'll test that by a blood-based test. If there's a resistance mutation that shows up in there that's targetable, great. That can then help guide what we do next. If there's not, then it really still requires a biopsy to make sure that you're getting that result to then guide the next line of therapy. At the same time, as I mentioned, suspicion about small cell lung cancer, well, you're not necessarily just getting that from the genomics. Sometimes you will see genomics show up, like on the blood-based test, RB1 loss, P53 mutation, but it's the clinical picture that would probably guide that suspicion more. So important to look for resistance mutations, and then we'll discuss the testing a little bit more later. Now, there are trials ongoing of EGFR-based EGFR inhibitors to add to the current standard of care. So right now, as I mentioned, Osimertinib, but studies that are looking at Erlotinib bevacizumab, Erlotinib ramucirumab, Gefitinib, and chemo.
On May 29, 2020, the U.S. FDA approved ramucirumab, a VEGF receptor 2 antagonist, in combination with Erlotinib for the first-line treatment of patients with metastatic non-small cell lung cancer with EGFR exon 19 deletions or exon 21 L858R mutations. This approval was based on the efficacy and safety from the global Phase 3 Relay trial, in which ramucirumab in combination with Erlotinib reduced the risk of disease progression or death by 41% compared with placebo combined with Erlotinib in patients with metastatic EGFR mutant non-small cell lung cancer.
And there's also Osimertinib combination studies as well. And so does adding VEGF receptor inhibitor to Osimertinib, does that help? Does adding chemotherapy to the targeted therapy help? These are studies that are ongoing, and other studies that have showed some interesting results thus far have really been those first generation EGFR TKIs in combination. But very important, very interesting data and important to follow up. So I'm interested to see what happens with these other studies. Now, EGFR exon 20 insertions really is a separate beast, so to speak. And this has been a really tough population to treat, and there are some targeted therapy studies ongoing. We're not really going to dive into those, but I do want to just highlight that those are happening. So one of the newer genomic alterations really is RET fusion, and we have two different drugs that have been in clinical trials. One recent FDA approval. RET fusions are noted in about 2% of non-small cell lung cancers. It varies a little bit from data set to data set, and these are true driver mutations. We see that this slide highlights the first generation RET inhibitors that were on prior trials, and we're really going to focus on these second generation, LOXO292 and BLU667, now Selpercatinib and Pralsetinib. As you can see, these are pretty focused to RET. FDA did approve Selpercatinib on May 8th, and this was based on the efficacy of the Libretto 001 trial. This looked at overall response rate, response duration, And the tolerability was reported to be pretty well tolerated on this. So Libretto 001 was RET fusion non-small cell lung cancer. You see 253 patients, 184 having gotten prior platinum-based therapy. And the waterfall plots are what we really want to see in waterfall plots. And this is really what we see in a lot of these targeted therapy studies. A number of responses, really almost all directed down on the plot. So decreasing size of tumors and very good response rate. So as I said, we do see pretty good response rates, and you see that here, a response rate of 70% in the 105 previously treated patients, and in 39 treatment-naive patients, we see a 90% response rate. Median duration was not reached with 27 of the 33. Confirmed response ongoing at a median follow-up of 7.4 months. Intracranial activity, also what we want to see. Not a lot of patients, but we do see clear indication of response within the CNS. Blue 667 now, Brigatinib, also ongoing trial, the ARROW trial, where we see ongoing responses. And this is really a promising drug as well. So 2 drugs, now one with an FDA approval, both look like they're really very effective at targeting RET fusion.
And Jacob, I think the really interesting thing also is that we used to think, oh, RET, it's tough to target. It turns out if you have a very selective and potent targeted therapy, the response rates can be excellent, as we see with the second-generation inhibitors.
Yeah, I think that's a really good point, because it really makes that, in the beginning we talked about that pie and the getting to smaller and smaller slices, and there are slices that weren't thought to be meaningful because we couldn't treat them, like you're saying. And now that we have better drugs, those really become very important slices to be aware of. And this sets a new paradigm then for other ones, some of which I know we'll get to, that have been thought to be very difficult, and now we're having a bit more success.
Absolutely. So MET exon 14 skipping is another target in lung cancer with the recent approval by the FDA of a targeted therapy. I think it's worth taking a recap briefly of the many different kinds of MET alterations that can be seen in cancers. So we're all familiar with the fact that there can be multiple different point mutations that occur in the MET gene. There's also amplification of the gene that can occur. And most recently, there's been a lot of attention paid on alterations in the gene that lead to skipping of exon 14, and we refer to this as MET exon 14 skipping. So why is this important? There are multiple mutations in MET that ultimately can lead to decreased MET degradation. There are many deletions, insertions, and base substitutions that ultimately have the effect of disrupting the splice sites that flank MET exon 14, and that leads to alternative splicing and skipping of exon 14. When that happens, there's impaired Sybil binding, and the ubiquitination process is inhibited, leading ultimately to decreased degradation of MET off the cell surface. And therefore, with increased MET receptor on the tumor cell surface, there's more signaling through MET and activation of the cancer pathways. There are multiple MET inhibitors in clinical trials, and we think about them in general as type 1 and type 2 inhibitors. Type 1 inhibitors include drugs like Brigatinib, Capmatinib, Tepotinib, Savolitinib. These are the more selective MET inhibitors. And the type 2 inhibitors tend to be multi-targeted, drugs like Cabozantinib and Metastatic. And we do think that there's a role for both types of drugs in treatment of patients with MET skipping. Recently, there was a new FDA approval for a MET skipping inhibitor to treat lung cancer patients. The FDA approved the MET inhibitor Capmatinib for the treatment of patients with MET exon skipping non-small cell lung cancer. This was based on data from the Genomic trial. The primary efficacy outcome of that trial was response rate, with a secondary outcome of duration of response. In patients who were treatment naive, they had never been treated for their metastatic lung cancer before, the overall response rate with treatment with Capmatinib was 68%. And in previously treated patients who had previously been treated with either chemotherapy or immunotherapy or some other therapies for their lung cancer, the overall response rate was 41%. And these responses lasted for a long time, many times for well over a year. This waterfall plot shows that both in the first-line setting and in the pretreated setting, The vast majority of these patients get shrinkage of their disease and the response rates that I just quoted before, with very good duration of response for those who are responding. So we know that there are excellent responses to Capmatinib in patients with MET exon 14 skipping. What happens in the MET amplified setting? The Geometry study also looked at MET amplified patients to see what the activity of the drug was in that setting. And in patients who had a high gene copy number, at least 10, the response rates were about 29% in people who had been previously treated with any treatment, and 40% in people who were treatment naive. So overall, not quite the response rate that we're seeing in the MET skipping population, but still some signal of activity in the highly amplified patients. There are also many other MET inhibitors in development. We talked before about some of them. Tepotinib is one that has shown great activity as well. Response rates that are reported anywhere in the 40 to 56% range. And here you can see the data that shows the PFS. And the interesting thing here too was they took patients and did the genotyping both by tissue biopsy as well as liquid biopsy. And this, I think, is a great example of how we can show that we really can test and find these mutations by liquid biopsies as well. And this opens up a whole avenue of kind of identifying these patients, especially in some cases where tissue may be difficult to obtain. Again, the response rates for Tepotinib were in the 40 to 56% range with good durations of response, as you can see here. There were some patients with brain metastases that were included in these studies, and you can see that they benefited from treatment as well. Finally, Savolitinib is another MET inhibitor that's been in testing, and in a phase 2 study looking at patients with metastatic MET exon 14 skipping non-small cell, an excellent disease control rate, the median duration of response not reached, and another MET inhibitor, another type 1 MET inhibitor that really shows promising anti-tumor activity as well. So Jacob, how do you think about MET skipping, and what do you do with these patients?
Well, this new FDA approval of Capmatinib is exciting, and this goes back to actually your prior comment with RET. I think this has been a challenging population. Now we have had Crizotinib, which has previously really shown some efficacy in MET, but this new approval with a drug that seems to work even better. But it's another demonstration of something that is targetable, and really getting better drugs, greater efficacy, makes that target become more and more important to identify.
Now, there are other targets which have been known for a longer time, and I'll go quickly through some of these. So ALK rearrangements, we know, is a targetable alteration in lung cancer. The ALEX trial really established Alectinib as our current first-line optimal treatment. This trial looked at Alectinib as compared to Crizotinib. And you can see at this point, there's been a 5-year update of overall survival, with a 5-year overall survival of 62% with Alectinib versus 45% with Crizotinib. These are all patients treated in the first-line setting. And one of the very nice things with this drug as well is that it has excellent CNS penetration. And we know many of these patients do have brain mets, and the ability to penetrate the brain is a very important aspect of this drug, as well as some of the other drugs we're talking about today. Recently, there was another approval of an ALK inhibitor in this setting, and this is Brigatinib. Brigatinib was compared to Crizotinib in the ALTA trial, and based on this study, which showed an improvement in PFS and a great overall response rate and intracranial response rate, Brigatinib received FDA approval for the first-line treatment of patients with ALK rearrangements. ROS rearrangements, we know, occur also in a small segment of our patients. Crizotinib is a ROS inhibitor, and it has been one that's been used with great effect in these patients. There's a very long median PFS. These patients seem to benefit for quite a long time with targeted therapy, and these are data from the profile trial of Crizotinib for the ROS1 subset. Recently, other drugs targeting ROS have been studied as well, and Entrectinib, we'll hear about a little bit later, as well as an NTRK inhibitor, but it also has activity against ROS1. And here you can see the response rate to Entrectinib in ROS1 patients was about 77%, a median duration of response of about 24 months. So another great option to have for our patients. And this is also an option that does have, we think, CNS penetration, which is a very nice feature for any drug to have. Jacob, do you want to talk about BRAF?
Yeah, so BRAF, and this is another one of the historically difficult to target now. Combination dabrafenib, trametinib. Again, this is what we kind of want to see in waterfall plots and what we often see within these targeted therapy waterfall plots. But overall response rate of 64% in the second line and 67% in the first line. Maybe a little more in the side effect profile than with some of the other targeted therapies, but overall well tolerated, good responses.
And TRAC, we know, is a small subset of lung cancers, but there are targeted therapies for this. Both entrectinib and larotrectinib have activity in this setting. And you can see these waterfall plots, response rates of 57% reported for entrectinib and 81% reported for larotrectinib. And HER2 is another target that we historically have had trouble effectively targeting. Jacob, is there any headway being made there?
Yeah, so this is looking forward. This is not yet standard of care, but in clinical trial, trastuzumab deruxtecan, we are seeing responses, we're seeing tolerability. This is an ongoing study, something to keep an eye on. But hopefully this will eventually become a demonstration like some of the other ones where we've talked about with where this piece of the pie has become important because we do now have targeted effective therapy. So ongoing study, not yet standard of care, but something certainly to keep an eye on.
Yeah, and I think it's really exciting along the lines of looking forward. The KRAS G12C inhibitors have had a lot of excitement, and I think that's a kind of whole new field opening up in terms of being able to target what was previously really thought to be untargetable. So the G12C inhibitors, there are multiple G12C inhibitors that are being actively studied. The AMG 510 was one of the first being reported out. These are granted small numbers of patients, but really encouraging to see response rates of around 50% in patients with G12C, KRAS mutations. Another G12C inhibitor that has reported out some early results is the MRTX 849, again showing very nice response rates, albeit in, again, small numbers of people, but this has really kind of led to a lot of excitement about being able to potentially target KRAS G12C. And there are multiple other novel KRAS G12C inhibitors that are in clinical studies. And I think this is an area where we're going to be having a lot more reporting out of combinations as well, and hopefully seeing some nice results in the near future. Jacob, what's your thought on KRAS and how we may be able to target this population in the future?
I'm so glad you asked because I really wanted to talk about this. Here, these have been pretty well tolerated. The data, as you point out, not a lot of patients, but impressive. I mean, we're really seeing responses in a target that really has been the challenge, and this is a good percentage of patients as we saw in that initial pie. So if we really get effective targeted therapy for KRAS, that would be pretty exciting.
So I think the key takeaways here, I would say, is the pie is ever expanding in terms of what we can target with better drugs and better understanding of the targets. We're actually able to better treat patients. And, you know, as we think about kind of the enormous advances that have been made in terms of being able to treat patients and have specific therapies based on these targets that we've discussed, one of the key things that we need to really focus on, and I'd love to get your thoughts on this, Jacob, is how do we make this happen? How do we encourage uptake, both of the testing as well as the treatment? Because we know that both aspects of this are so important to get our patients the treatment they need. Jacob, what's your sense of how this is being taken up, both in the academic community as well as community practices?
Yeah, so to be focused on lung cancer is an incredibly exciting time because there's just so much happening and so much coming. I think within the community where oncologists are taking care of all cancer types, I'm always impressed with that because to try and keep up on all of that is so much. With so much happening in lung cancer, that really just takes so much attention to be up on this and really increasing the testing. So 2 new FDA approvals just recently. That means that whatever panels were being done before have to now incorporate these. And so increasingly, and I know we'll talk more about this, but increasingly we really have to make sure that treating oncologists have to make sure that they're really testing for all of these targets that really have FDA-approved therapies. At the same time, this is such a big shift in hope. I mean, in the treatment options and what's available and what can happen and what's possible. In the last 10 years in lung cancer, we've just seen such a change. And so sometimes amongst the kind of other outside of oncology medical community, maybe primary care, and certainly amongst the public, that lung cancer diagnosis, what they perceive as being possible and what we discuss when they come in for a visit can really be different worlds, because in the last 10 years it has changed so much. And genomics testing is such an important component of that. So all patients, we really push, make sure you're asking about genomic testing, make sure you're making sure that you've gotten full panels in this. And I think this is, if there's one take-home message from this for oncologists across the country, it's really make sure you are capturing every possible genomic target or alteration that has an approved therapy at a minimum, and be aware of the fact that there are some exciting clinical trials going on, so that even some of the ones beyond what have FDA-approved therapies, you want to be aware of, because those are people that may really benefit from referral to centers that have these clinical trials open if you don't have it open in your center.
And so Jacob, let's get to the nitty-gritty here. We've talked about the importance of broad panels so that we can identify these targets. Who needs to be tested? Who are you testing? Are you testing only patients with advanced disease? Are you testing stratified by any factors? Let's go through these one by one.
Anyone with a non-squamous, non-small cell lung cancer that's metastatic, absolute standard of care. And we're doing NGS panels. I think many centers are doing NGS panels to really make sure that you're capturing everything. That helps capture not just all the approved therapies options, but some of the rare mutations that can happen, or rare specific mutations within those categories, as well as just getting all different alterations that may have trials options and stuff. NGS panel is really going to capture all of that for you. Some of the centers are doing more targeted therapy, and we'll talk about that a bit more in a moment. So full panels, all patients, non-squamous, non-small cell lung cancer that are metastatic. Squamous cell lung cancer and even small cell lung cancer where patients are never smokers, we get that as well. So squamous cell, we certainly see targets. And it brings in the question of whether that there are patients who have squamous versus maybe it's more of an adenosquamous, but just the specific site of biopsy is the squamous component. But someone who's a never smoker, we do see targets that show up, and that is guidelines. And even small cell lung cancer in NCCN guidelines, recommendation for never smokers is to get that. Now that's more rare, and I have a little more than a handful of these people, never smokers with an initial diagnosis of small cell lung cancer. And I've found that really in some of these patients, we do have an alteration that's targetable, and then kind of retrospectively as we analyze things more, sometimes on a repeat biopsy, these may not be a clear-cut small cell, but more of like a neuroendocrine non-small cell, in which case those patients should get genomic testing as well. So all non-squamous, non-small cell, smoking history doesn't matter, all of them. Anyone with a never smoker history or a very limited and years past smoking history, I would check it in squamous and in small cell.
Yeah, and I would emphasize, I completely agree with all of your points. I do think that it's important as we think about some of the newer targets that we do find them across all histologies. So for example, MET skipping is something we find it's prevalent predominantly in adenocarcinomas, but we have seen it also in squamous and adenosquamous. And there also seems to be a higher prevalence of it in sarcomatoid carcinomas, which historically has been a very difficult histology to treat.
Earlier stage now, that becomes a question mark. And there are trials ongoing, and these are important trials to evaluate, does targeted therapy earlier on matter? And there's some data to suggest, but we still have more data to collect in that. These trials are very important, so it's important to keep enrolling to these studies.
In the Phase 3 ADAURA trial, patients with stage 1B, 2, and 3A EGFR mutant NSCLC with complete tumor resection and optional standard postoperative chemotherapy were randomly assigned to receive adjuvant Osimertinib or placebo for 3 years or until disease recurrence or unacceptable toxicity. Results from the first interim analysis were reported at the 2020 ASCO annual meeting on May 31st. In patients with stage 2 to 3A NSCLC, adjuvant Osimertinib improved disease-free survival by 83% versus placebo, and the 2-year disease-free survival rate in patients with stage 2 to 3A disease was 90% with Osimertinib versus 44% with placebo. When adding in earlier stage disease in the overall study population of stage 1B to 3A NSCLC, Osimertinib improved disease-free survival by 79% versus placebo, and the 2-year disease-free survival rate was 89% versus 53% respectively. Results were so positive in favor of Osimertinib that the Independent Data Monitoring Committee recommended unblinding the trial early, and plans for regulatory submission are already underway.
As these new targets come online and there are FDA approvals for them, it is important to test across all histologies as well as across all age groups. I think historically we used to think of, the never smoking young patient would be more likely to have one of these alterations, but we know as the number of alterations increases and we're testing for BRAF and MET skipping, that older age groups are included as well as all smoking histories. And so to the question of, who gets tested, I think anyone with lung cancer should be tested so that we have the best kind of array of options that we can present to people.
Yeah, and that goes back to that sense, in telling patients, I want to put you on the best therapy, not the first one. And getting the genomics is really what helps assure that you're treating them with the best therapy.
Absolutely. And now how to test. How do we test for these alterations? There are so many tools available. It's actually very hard to keep up with all the different ways in which you can do this testing. Do we do it one at a time? Do we do a broad panel? Are we looking at DNA? Are we looking at RNA? Should we be doing biopsies of tumor for everybody? Or are there some people where you would do liquid instead or in addition to at initial diagnosis or at disease progression? I think the question of which molecular testing technique to use is something that we all grapple with actually, and is actually probably one of the hardest things to deal with because of the wide range that's available. This is frankly a time where I very often will ask my pathologists, for advice. Is this test going to cover what we need to cover? I think this is a really nice chart that shows for the different alterations that we currently know are important to know about in lung cancer, what do the different testing modalities let us investigate? So tissue PCR was historically how we tested for most of these alterations, and you can see it's quite good against the point mutations, against EGFR, HER2, BRAF, and KRAS. It's not very effective against rearrangements, and obviously it doesn't get us PD-L1 either. Tissue FISH is another methodology. This is actually pretty intensive in terms of kind of needing slides to do this as well as pathology expertise in reading the FISH. But it does get us a good look at the rearrangements that we're interested in. IHC is a modality that has been around for a long time and is really useful for PD-L1 status as well as ALK IHC, but it doesn't really get us the other information we need either in terms of point mutations or rearrangements. And then tissue-based NGS does get us much of what we're looking for. It doesn't get us the PD-L1 testing, but across the various point mutations and rearrangements, we do see good coverage. I would say amplification is one area where tissue NGS may not, or NGS in general, may not be quite as robust as some of the other areas at the current state, but I think that will probably change in the future. And tissue-based RNA actually adds to what the DNA can find. We do think that looking at the RNA can give us a deeper look at some of these alterations that we're looking at. And then, of course, the liquid, both the PCR and the NGS on the liquid samples can give us this information in a complementary way as well.
Yeah, that was a really good summary. And I like your comment of saying that you work with pathology as well. I think the challenge is if you're doing like a PCR test, so those can be very fast and you send that off. But if you're doing one by one, then for many patients, that becomes, now you have the time to get that one back, then you have the time for the next one, the time for the next one, and you have to follow those up quickly. I think by just doing the panel itself, now that we have increasing numbers of those who really, you need all of those, that becomes more and more justified, as I mentioned.
Yeah, I think the sequential testing, first you check for EGFR, ALK, ROS, and then you check if those come back negative for KRAS, and then you check for a broader panel. The sequential testing is really challenging now that we have all of these approvals in multiple different targets. And, while that was an approach that I think was held for many years and reasonable, especially given the limitations of time, as you said, and tissue, doing a comprehensive panel up front seems like the best kind of way that you can get to treatment the fastest.
Yeah, it's important. And for those who do choose to do one-off testing, if for whatever reason are choosing that, you just really have to make sure you're following up and getting all of them. Because if you're missing any of these and patients miss out on these options, as we showed, these waterfall plots are impressive. For the most part, tolerability is really very good. And so these are really excellent treatment options for patients. These are really some of the more impressive patients that we see. So if you're gonna do that one-off, then you just have to make sure you are not missing any of these, and to also be aware that if you have someone that really fits the classic population that doesn't, that you're not finding something, then you probably need to dig deeper on those. So that's where, an NGS panel, you might find something that's a bit less common. At the same time, I'll ask the question, Becca, RNA. I think there are some centers where if the DNA testing isn't showing something, if you're really suspecting it, what's your threshold then for kind of next level in doing RNA testing?
Yeah, so that's a great question. And I would say that our institution, we frankly send both right from the beginning, that we're doing NGS based on DNA as well as NGS based on RNA. As especially for the fusions and rearrangements and things like MET skipping, actually, it allows you to look for the actual fusion event or the rearrangement or the missing exon, kind of agnostic about what caused it, what's the partner. And I do think that's an important piece, that RNA can pick up some things that DNA won't as easily. Jacob, how do you approach testing when you're thinking about all of these different ways that it's possible to do testing?
I think, the way I generally go about it is kind of keeping it simple. So I'll send off the NGS panel, do the NGS testing, and if that's not showing something and there's someone where I suspect, so a classic population where I have a higher suspicion, then it becomes, what are we missing? What else could there possibly be? And so whether that be RNA testing or potentially FISH testing is really a discussion to have with pathology.
And so are there limitations to NGS? We think it's quite good at getting us all the point mutations we need to be looking for. But Jacob, what do you think about potential limitations? Are there limitations in amplification and fusion?
Yeah, generally pretty good with fusions, but can miss fusions. So fusions and amplifications, I think if you're missing something, that's probably going to be something more in that category if you're doing NGS testing. So how to then capture that, and that's why I say RNA or FISH, and that's a discussion to have with the pathology department. I think the thing is that most pathology departments are pretty capable of doing FISH testing, and so I find that pathologists tend to like FISH testing, and some of the RNA-based testing is maybe a bit newer. So that's really a matter of a discussion within departments and what your department is capable of. And the expertise within your department. Again, we talk about NGS panels. That really is the way to capture as much of the data and the details. And now that we have so many targets, it just becomes more and more justified in just getting that panel. But we have two different ways of doing that now with tissue-based or blood-based testing, and so which to do and when certainly becomes a question mark. The blood-based testing, certainly easier. I'd say we get the results a bit faster, particularly if to get tissue you have to schedule a biopsy and such, and then sometimes that biopsy doesn't have enough tissue on it. Sometimes that could be even a repeat biopsy. In the worst scenarios, most of the times it does in fact have enough. But there is certainly an ease to blood-based testing. I think one really important point to make, just in the middle of this discussion, I guess, is that a blood-based test that does not show a mutation, or for that matter, a tissue-based test that does not show a mutation, does not mean that it's definitely not there. And so particularly if you have a high suspicion, you really need to dive deeper for those patients. So previously I talked about in Osimertinib, when someone has resistance to Osimertinib, and then we're looking for resistance mutations, oftentimes we'll send a blood-based test. It's easy to order, you get it on the way out of the clinic, send it off, and oftentimes we do have that result back a week, within 2 weeks certainly, and so that's a pretty good time frame, pretty quick time frame. If that doesn't have a resistance mutation that shows up, if there's not something that makes me more confident that it's not there, then we do a biopsy and look at that as well. And to have the two of them really assures that you're capturing as many as possible. And so I think that's important. Now, someone off the bat, if you have a new diagnosis and there's not enough tissue for initial testing, they're going to have to get a rebiopsy. Well, sending a blood-based test to help get that result can sometimes prevent a biopsy. If that blood-based test shows a KRAS mutation, then I don't necessarily get a biopsy to look for EGFR, ALK, and these types of things. So then you can actually trust that they don't have those mutations in there, because KRAS doesn't really we don't tend to see those together. So if I see something like that on the blood-based test, it spares a tissue biopsy. Or if I see a mutation that we can target, that often can then guide the therapy in itself, otherwise than tissue. But we really do NGS panels as a way of making sure we're really capturing all of these.
Yeah, I think as we think about tumor and liquid biopsies, there are a few studies that it's really worth kind of talking about, so that we kind of add some context into what informs our decision making. One is a study done by Dr. Agarwal at Penn, and she looked prospectively at patients with lung cancer getting concurrent plasma and tissue NGS, as well as patients who had plasma NGS only because tissue was not possible. And I think the really important thing about this slide is exactly what you said, Jacob, that these approaches are complementary, that there are some people for whom there's not enough tumor tissue, that we can't get the tumor biopsy. And of course, in those patients, the plasma gives us a very nice sample to at least start looking and see, is there any data there that we can act upon. And then for patients who get both plasma and tissue NGS done, there's good concordance between the two on multiple targets. And there's complementary additive benefits to each. So she found that there were some where it was detected on the plasma and not in tissue, and others where it was detected on tissue and not on plasma. So I do think these are complementary approaches as we think about how do we make sure that we have tested for all the targets that really we can act upon for these patients. Getting back to your point, Jacob, about the sequential testing, the Nile study was another important study that informs our thinking. And I think one of the important things to think about here, this graph shows that in patients who were tested with tissue first versus plasma first, it shows the percentage of guideline recommended biomarker detected by the testing modality. And it was surprising to me that the tissue first was lower than the plasma first. But then when you dig into it and think about what they were measuring, it makes a lot of sense, because these were patients who were getting standard of care testing. Many patients were getting sequential testing, and we all have run into the situation where you've run out of tissue, or you got some of the markers but couldn't get all of them. And I think the Nile study shows an important way in which plasma can be very helpful, especially if there's limited tissue available, or in sequential testing where, as you say, you really have to be kind of pursuing that, and if you're getting negative tests, going on to the next level, which can be difficult to kind of make sure it gets done in a timely way.
Yeah, and especially when we're talking about in the first line setting, patients are anxious to get started. They have a new diagnosis they've read a bit about, or people react when they tell them that they have lung cancer. I commonly have patients tell me that when they get first diagnosed and they tell people they have lung cancer, people respond, "But you look so good." Because I think the expectation is now that you have this diagnosis, you're just going to crumble. And so even people who are doing well, where clinically we say, hey, we're not actually worried about a few weeks of ongoing workup to really make sure, but patients are. And so I think they're frequently pushing on, hey, when are we going to get started? When are we going to get started? And this speaks to, making sure that you really do get the full workup before getting started, assuming they are someone that can clinically wait for that. But there is some urgency to that, and we really want to make sure that we get all those results back.
Yeah, absolutely. I think the getting started on that first treatment, it is so time critical, and making sure that we are bundling everything so that we get all the information that we need to kind of make that great first treatment decision is really important. So as we think about best practices for molecular testing in patients with advanced non-small cell lung cancer, there are many things to kind of focus on. One is selecting the right assay. We need to make sure that the test can detect all the alterations we're looking for, all the targets that we've talked about. So in addition to point mutations, being able to detect gene fusions. It's very important to consult and collaborate with the pathologist that you're working with so that you understand what does the assay cover and what is it not covering, so that I can make sure that the patient gets all the coverage of all the targets that we need to know about. When to perform molecular testing, we think it's really important that all treatment-naive patients should undergo genomic testing. This is really at the point of diagnosis so that we can decide, as Jacob said, on the best treatment up front. And we also think it's really important that both tissue or plasma-based testing be done when patients develop resistance or disease progression, because there are resistance mechanisms that we can target as well. And finally, in addition to our pathologists, it's also really important to communicate with the colleagues who are doing the biopsies, because as we've talked about, having adequate tissue to do all of the testing that we want to do is really important. Jacob, when you're diagnosing a patient and thinking about the testing that you want to request, how do you deal with this and all of the different collaborations that go into this?
Well, this is one of the things I love about oncology, is it really is a team effort. So we have tumor boards where teams come together because it's important for all of us to understand other people's roles and what other people need to help make sure that we're doing our part to help them as well. So it is a collaboration with pathology and with those doing the biopsies and such. I think that the teams doing the biopsies have really gotten the message. I mean, more and more, we keep saying more tissue, more tissue, more tissue. Now that we have the blood-based test for DNA that maybe helps sometimes when we don't have enough, but we still want it because also enrollment to clinical trials and such. So that message has pretty consistently been more tissue, of course, safely. And then, I just want to highlight, this really is important, this collaboration with pathology, because it's going to be different in different centers. So, we've really highlighted doing an NGS panel gets you as much information as I think matters for most patients. Most patients, that's going to be sufficient. But then there are still going to be some where you say, hey, I really suspect something, and this test is not showing that. So what can we do next level to further evaluate this person? And the workflows for how best to do that in different institutions are really going to be a collaboration between medical oncology, making sure that pathology understands all of the clinical importance to these testings for treating patients, and then pathologists, of course, in their workflows within pathology and within the institution. And it has to be a collaboration in how to work together to really provide every patient the best treatment available to them.
Absolutely, and I think what we really want to do is move the needle from no genotyping, which really would not be acceptable in today's day and world, through incomplete genotyping, which is some but not all of what we need, into effective genotyping, which is really testing and making sure that we've covered all the targets where we can actually have treatments. So the availability of NGS assays with a high PPV means that today no patients with advanced lung cancer should receive no molecular testing or just PD-L1 testing. That's not enough. But the limitations of our genotyping assays have to be recognized to avoid incomplete genotyping. Targeted assays for common driver mutations take time. It can exhaust tissue, and this is where the collaboration is so important. And we do know that the rarer driver mutations are important to look for, because if people have them, there are drugs that are extremely helpful in that situation. And then plasma analysis has imperfect sensitivity such that targetable driver mutations can be missed. And if there's a positive mutation found, then great, that's something that we feel we can act on. But if they're negative, then further testing with tumor to back that up is really important. So to offer our patients effective genotyping, the most reliable approaches involve either a panel-based assay on high-quality tissue or plasma DNA analysis first, followed by reflex to tumor genotyping if the liquid biopsy is negative for a targetable alteration.
Yeah, I mean, just to highlight that, ineffective genotyping is just not acceptable. And to further highlight that, you know, I have a handful of people who were essentially being put on hospice and reached out as kind of a last-ditch effort. And you know, some of them were diagnosed a while back. So at the time of initial diagnosis, BRAF V600E didn't have an approved therapy, and so they didn't have that testing at that time. But at the time when I was seeing them, that is something available. And looking back through their genomics, they'd really just had, this individual had had kind of a smaller panel. So sent off a test, an NGS panel, came back BRAF V600E, and this guy has responded very well for a long time on Dabrafenib, Trametinib, significant response to therapy with shrinking of his very large adrenal metastasis. Someone else that was on targeted therapy for RET fusion at the time, that's on clinical trial. But you know, these individuals, we're talking about significant changes. These people were essentially looking at hospice and now have had, in some cases, years of ongoing response to therapy. And just to really hammer this home, you know, 10 years ago, we're talking about overall survival for non-small cell lung cancer really being less than a year or kind of pushing a year. And now we're talking about a lot of these different targeted therapies with progression-free survival. So not even survival, just ongoing disease control in the first-line setting for 18 months, 3 years. This is such a significant change. And at the same time, you know, when I talk with patients about what to expect with their treatments, I say, you know, when you're looking online, because some people will start reading online about survival and stuff, when you're looking online, that is the average looking backwards. But we're going to do this going forwards. And as people are seeing, you know, in this discussion, we're talking about such rapid progress happening with these. Going forward, you know, hopefully this will really continue, and we'll continue to have better drugs for these targets going forward. And so it's really an exciting time to be treating people. Nobody wants to get a diagnosis of lung cancer, but treating these people with lung cancer, we're really getting better and better therapies going forward, which is helping people live longer lives, and not just live longer, but with better quality while living longer. So really just seeing wonderful responses, and it's so important to make sure we're really giving every patient that option.
Absolutely, and I completely agree with you. I think so much of the major advances in lung cancer treatment over the last decade has really been because of identifying targets and having drugs that can inhibit those targets. And key to that is getting the genomic testing done and testing everybody at diagnosis. And then people in the past where there was incomplete testing because we didn't know that these targets actually were targetable, finding them and testing them with the bigger panel again. I think that is actually a very important thing to do for our patients. And more uptake of this genomic testing is really important for the patients in our centers and our community.
Yeah, that's absolutely right. And even people who did get testing initially years ago or a year ago or whenever, if they got just a blood-based test, for example, that didn't show something, well, that's not complete testing then, unless it showed a KRAS mutation or something. But So on these people, even when they had something, then maybe it's worthwhile going back and really making sure they had complete testing because you can miss something.
Absolutely, and I think as we continue to evolve and work with our colleagues in both the interventional fields, doing the biopsies, as well as work with our colleagues in pathology, as we do more and more of this testing and move towards NGS, it's an exciting time to be practicing lung cancer medicine. And I think the future is very bright in terms of targets for lung cancer and more treatments that are becoming available for our patients. So Jacob, thanks so much for joining me today. It was fun to talk with you.
Thank you, Becca. Really enjoyed the conversation.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/NEN860. This activity is supported by independent educational grants from AstraZeneca, EMD Serono Incorporated, Lilly, and Novartis Pharmaceuticals Corporation. For further information concerning Lilly grant funding, visit www.lillygrantoffice.com. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer View Institute for Medical Education.